Everybody, I'm here lecturing from my kitchen this time instead of the empty classroom. So still kind of weird lecturing to nobody, so please put your comments underneath so I can answer your questions and so I don't feel like I'm talking to myself quite as much. Workbook questions, mind tap questions, anything about the chapter that you don't understand, please put your comment underneath the lecture. I will make a post about this, but from now on I'm going to make that part of your participation grade online. So I need you to comment underneath one of the lectures, ask me anything that will count as your participation grade in this lecture. So I want to ignore the craziness that's going on with the world for a minute and let's focus on plastic surgery. So we'll start on page 724. There's not a whole lot of introduction into this because a lot of people have an idea of what plastic surgery is already. I don't want you to think of that cookie cutter plastic surgery that most people think of, because a lot of what you're going to see is reconstructive surgery. So it is plastic and reconstructive for a reason. So as far as the introduction goes, there's not a whole lot to add. The diagnostic tests I'm not going to get too involved with because you know it's going to be x-rays, CTs, and MRIs. For plastic surgery, mostly x-rays, but there are some like craniofacial things that they might have to check out at MRI with. Let's get into the instrumentation and equipment supplies that you're going to need in the room. So as far as supplies, it's going to be very specific per surgery, but instrumentation is going to be pretty much the same way. So it's got a general plastic tray. I do want you to be familiar with those instruments. Most hospitals will have a general or basic plastic tray, but you're going to have one per specialty typically. So one for breast cases. They already have separated for you the rhinoplasty set. They might have something separate for liposuction, like tulip cannulas. So they're all going to be separate instrument sets per separate surgeries. So make sure you're familiar with the plastic tray, the rhinoplasty tray, and then read about your dermatome. So if you don't remember your dermatomes, what you're going to take skin grafts with. So I want you to know the difference between full thickness skin graft and split thickness skin graft. When it comes to studying that part, you should study what they're using differently. So one, they're going to mesh graft, and another one, they're not. So make sure that you know the difference between those. So as you're studying this, if you're looking at page 726, the picture they have, the oscillating blade dermatome, that's what we're talking about. So where it says other types of dermatomes, I'll post pictures of those for you guys, but typically we're going to use the oscillating dermatome. So that's what I want you to focus on. So the oscillating dermatome is going to take a skin graft, and then if they are going to mesh it, they can put it through a meshing device. And they have a little plastic carrier for that they're going to mesh it through before attaching it to the patient's skin. I would rather go over the more important things for skin grafts. So things that you need to pay attention to. First of all, it's a powered instrument. Usually it's pneumatic, so it's hooked up to nitrogen. So you want to test this and make sure safety's on, all of those things before you use it, just like a drill. It's got a big blade that you're attaching to it also. I have told this story, but you get to hear it one more time. So my instructor made a giant mistake that impacted a patient. So she put the dermatome blade on upside down. So it clearly says this side up on the front of it. But of course you're in a hurry, you're getting it ready for the surgeon. She put this side down. So when they went to take the skin graft, it dug deep into the anterior thigh and took part of the muscle with it also. So not only was the skin graft useless, but now we have a big hole in the patient's leg. So they had to take another skin graft from the other thigh. That worked well and they grafted it, but they ended up having to take another skin graft to cover the defect that was made on the thigh. So I cannot tell you how important it is to make sure something as simple as the blade says this side up on it. So it's going to make a big impact on your patient's life. So there's the scary story, this side up on your dermatome blade. There's some other things you're going to need to, and I made a list for that on your PowerPoint that I will post today. So you're going to need some Adson tissue forceps to kind of grab the skin as it comes out. Some people like to use a tongue depressor, like a popsicle stick to kind of hold that skin flat. Sometimes they just use the scrub tech. So they'll ask you to get a lap on either side. Basically, your thigh isn't nice and flat, right? It's up like this. So it's your job to flatten it out for them with a lap on either side. so that they can come with the dermatome and take that skin graft where it's nice and flat and straight. So that way they get a good skin graft. A lot of surgeons use mineral oil on this dermatome and on the dermatome holder, so the graft holder. So sometimes you'll need mineral oil. A lot of surgeons like to use a Ratex soaked in epinephrine right after they take that skin graft. Because think about, you've just made a big square that you have bleeding now from all the different pores because you just took a skin graft, and they want that bleeding to subside. So you're going to take your soaked Ratex and epinephrine, unfold it, and lay it on top of where you just took that skin graft from so that bleeding can stop. And of course that's a countable item, so you know it's not going to accidentally get tacked on as a dressing, so that's why we use a Ratex and not a 4x4. So lots of different things to learn about skin grafts. That's actually just in the beginning with the intro with instruments, so we'll get into more detail with that. Most importantly for you when you're studying, I want you to think safety. So there's a pearl of wisdom on 727. It's making sure that you're not connected to power when you're starting up your dermatome the first time, because you can injure somebody. But I'm going to give you more tips as we go through, like the one I just gave you about the blade, to make sure you're using this properly. As far as your grafts, on page 727, I went through this the last time with OMF, so I'm just going to tell you to study it. So know the terms for all your grafts, autografts, xenografts, etc. Make sure you know them all. Okay, your anatomy. So it goes into the instruments, talks about dermatome, and then it switches to anatomy. So you know I don't usually do an anatomy review, but I posted one for you so that you can go over the integumentary system. As far as you studying, I will point out what you should study. So integumentary system, know all of the layers. So stratum basale is your first one. That's your base. So start at the base and work your way up. I will give you a helpful hint though. If you are looking on 728, numbers 4 and 5. So we start at stratum basale, spinosum, granulosum, then lucidium, and corneum. So those two are going to be your outermost layer. Some people get that mixed up. So they're going to think number 5, stratum corneum, is the outermost layer. That's true for your normal skin. What about your thick skin? So palms of your hands, sole of your feet, that's going to be your stratum lucidium. So make sure you know all the layers. Make sure you know the difference between the reticular layer and the papillary layer. Know all your glands. Know your sebaceous glands and what they produce. Know your sudiferous glands and what they produce. As you're studying those, they typically talk about two, right? They talk about the merocrine and the apocrine sweat glands. I do not want you to forget the third type of sweat gland, your seminiferous glands. So that's talking about near your ear. It has to do with earwax. You got to know all three of those. So study your anatomy. On page 730, it talks about burns because that's typically what we're going to be doing skin grafts for. There are other defects we can do it for, but a lot of burn patients are going to receive skin grafts. So know the difference between first, second, third, and fourth degree burns and all your terms that you need to know for that. As far as how deep they're going to go with these skin grafts for burns, you should check out the bottom of page 730, and I'm also going to post a picture with that too. So it makes it very precise for you for how deep they're going to go for a full thickness versus a split thickness skin graft. On page 731, you should definitely study your rule of 9, and after that, it gets deep into the difference between full thickness and split thickness skin grafts. So now that I'm there, page 732, I'll go through some more items that you're going to need. So I've mentioned Adson pickups. I don't know if I said this, they should be Adson smooth. So Adson forceps smooth to make sure we're not damaging that skin graft when we grab it. I told you Ratex with epinephrine to put on the skin. As far as taking the graft off of the dermatome, so they're going to go across with the dermatome, it's still stuck to the skin. So at that point, you have to have either a knife or some tenotomy scissors to cut off that skin graft so they can then keep it for where they're going to graft it. When they say keep it, if they hand you a skin graft, you should automatically go put it in saline. If it's not in saline, it should be on that dermatome graft holder. So this is basically a piece of clear plastic that's going to hold your skin graft. It needs to be on one or the other because the skin, it needs to stay moist. So if you let that skin graft dry out before they get to use it, it's not going to be usable. So either in saline or on that dermatome carrier, the only reason it's okay on there is because it's covered in that mineral oil. So it's nice and lubricated, so it's going to be ready for the patient.